With us this evening is Dr. Francine MacInnis, and she is a clinical and organizational psychologist with more than 20 years of experience working with individuals, teams, and organizations on topics related to mental health and well-being. It is her clinical work. In her clinical work, she uses a variety of approaches, including cognitive behavioral therapy and positive psychology, to help her clients apply sound and healthy practices that reduce symptoms, for example, anxiety, depression, and anger, and increase their feelings of engagement and satisfaction in their lives. Currently, she is a staff psychologist with the Emotional Health CBT Clinic at the Queen Elizabeth Health Complex. I think you may know that's down in NDG. Dr. MacInnis also works with organizations to promote and develop a healthier and more productive work environment. Please help me welcome Francine MacInnis.
Thank you very much. I'm going to try and, I'm a bit of a mover, so I've been told this is my post. We'll see how we do. But I don't want this to be too one-sided. So at any point during the presentation, I'm here to present some information. I'll present you some basic facts, both about OCD and about CBT, a little bit of alphabet soup tonight. But I don't mind if you have questions that are related or burning questions about something mental health related, individuals, teams, organizations. I'm happy to field those. So you feel free. Beverly is there. She will come around and bring a microphone to you if you have a question, or you can bring me a little sticky up here and I'll try and see if I can get to it during the presentation. Because what I mostly want is for you to leave having answered a question that you may have brought along coming to this evening. All right, so shall we get started? All right, so tonight we're talking about obsessive compulsive disorder, and I'm going to give you sort of some technical information about what it is. Feel free to ask me questions. It can be a little bit of a nuanced thing trying to figure out how this is same and different from other things you might already know about. So let me just first start with what it is. So OCD is recurrent intrusive thoughts, images, or urges. So somebody was asking about the O in OCD, the obsessions, that typically cause anxiety or distress, and repetitive mental or behavioral acts. So that's the C part of OCD. So there are intrusive thoughts that come, or images, and then there's an urge to act. There's an urge to engage in some behavior to try and manage the intrusive thoughts that come. And these are things that the person feels compelled to do as a way to handle the thoughts and images that come. So in response to an obsession, and it tends to be a pretty rigid rule that will develop around what they need to do and how often they need to do it in order to try and handle the thoughts that come. One of the things that's helpful to know is that a lot of the things that will get stuck in the mind of somebody who has OCD is things that we've all thought about at some point. And the difference is that for us, it's a fleeting, random, weird thought. So people will often, because we all have weird thoughts, might be walking across a bridge and thought, oh my God, what if I pitch something over the side? Or what if and then they just kind of go, whew, that was weird. And then they keep walking across the bridge. But for some people, there's a thought that comes and they think, oh, that was scary, that was weird, and it sticks. And so it can be cultivated into something that becomes an actual worry. Oh my gosh, what if I really did that? That would be terrible. I must not do that. And so it can get groomed in the mind as something that stays there. And then things will come along. Actions will come up. I could protect myself from that or protect others from this if I just do this action, or if I just engage in this other thought as a way to sort of counteract that. So it's not so much that the thoughts that come are so unusual or so strange. It's that they get stuck with those thoughts. So, and I find oftentimes it helps people that we work with to know that the stuff that they've thought about, because oftentimes that's a little inkling that's particularly distressing to them, is to think, what on earth is wrong with me that I would have that thought? I must be really X, Y, or Z. I must be a really bad person. I must be a really scary person. I must be a really crazy person to have had that thought. And it's important for us to talk to them and let them know that we've all had those thoughts. And they research such things. They have looked into this, and they have discovered that the nature of the thought itself is frequently generally not what distinguishes people with OCD from people who don't have OCD. And so it's important for them to not only normalize so that they feel less broken or less sick or less out there, but also to know that that in and of itself isn't an indicator that things have gone really wrong, because often they're scared of themselves and scared of their own thoughts. So it's helpful for them to know that we have all had these thoughts at some point, and we're trying to help them get unstuck with some of these thoughts and the behaviors that go with them. Good so far? Okay, good. Whoops, need to keep, and it's over. Thank you very much. Okay, some basic information about OCD. So it's estimated about 2% of the population. Mostly it shows up in adolescence or early adulthood. You've probably attended some of these talks about other subjects, depression, anxiety. It shows up when things commonly show up, which is in adolescence and early adulthood. That's when it tends to manifest. And some part of that has to do with what's going on at these periods in life, because there's a lot going on in these periods of life. Oftentimes, there's a lot of pressures in high school, there's a lot of pressures in moving away from home, and it tends to kind of stir things up particularly. Now, if it wasn't in the person at all to ever develop OCD, regular stresses of school does not create OCD. But being under a great deal of pressure certainly does stir things up, and we're more likely to see a lot of the emotional difficulties in these periods because the person is under a lot of pressures. So oftentimes that's the first time we see them. So I see lots of people in their teens and their early 20s. But frequently, when I'm talking with them and we look back, there were little glimmers before that were tolerable, or that were not quite as developed as when it really comes into kind of fully present state. And so oftentimes people are worried that going to school or the normal pressures of life created this. So that's not really the worry, it's just how it tends to present itself. Symptoms can range from mild to severe. And that's often a question that I get is, if you have any of these symptoms, do you necessarily need treatment? So that's where there's a bit of a judgment call in the mild to severe range, is that there's two schools of thought. If it's mild and it's tolerable, and you know what it is and you can manage it, maybe you don't necessarily feel like you want to put your energies and your attention into the treatment. And you're also probably less motivated because you're handling things okay. That said, I am impressed that we have a lot of young clients who say, I want to get this before it gets out of hand. And I think there's some real wisdom in being able to get a handle of things before it's in a moderate to severe range, because it's much more difficult. So in that way, it's similar to other disorders that you might think about, including generalized anxiety or depression. When you're in the grips of it, it's much harder to find the energy and attention and motivation to get out of it. So if you're seeing symptoms of it, it's good to keep an eye and maybe even go in and talk about it to kind of get a sense and another point of view on how intrusive it is, how big it is, how much it's maybe starting to interfere. And at least then you've also already made that foray into consulting if you need it. And if what you've discovered is, yeah, I'm okay, no harm done. But if it's something that you feel is starting to take more space, maybe you want to start working on it right away and bring it down to its lowest point. The difficulty is once it's in a severe range, it's a very difficult process for people who are in the severe range because they really feel in the grips of it. And working on OCD is really trying to find a bit of loosening here because people are fully believing what's going on. And so that they hold tight to it and the compulsions and the rituals because things are very, very scary. So it is absolutely treatable in the whole range. But if you're seeing things in an earlier stage, it's useful to see if you can intervene and try things because things are a little bit looser. Like you start noticing and you're observing, but you don't feel necessarily in the grips of it. And that helps for people because you end up having to tinker with, experiment with, try and loosen up some of the rituals. And that goes against the inclinations of somebody with OCD. So that's just something to think about when you're looking at symptoms. I wouldn't dismiss it. I would see if there's some openness to read more and try things. Maybe you can do some of your own work. There's lots of handy workbooks out there. And you can do some of the work on your own if you don't feel like you want to go into a treatment process. But I would be inclined sooner than later, like eating or anything else. The earlier you intervene, the more of a handle you can get on things. All right. Untreated, though, the impact can be quite significant. So some people have little minor rituals. I would argue that if I followed you home and watched you, you probably have some. We all recognize ourselves as having little bits of this, and I would be the first to put my hand up. Things don't always need to be at right angles. That third swipe across the counter wasn't necessary. So I think we all have little bits of it that we can just say, okay, we don't need to worry about this. It's not consuming. It's barely distressing. We're just noticing. That's something we don't need to worry about. Because again, some pieces of this exist in the general population, in all of us, basically. But it can get quite severe where people are spending hours each day. So it's extremely distressing, and their rituals can consume several hours a day to perform. And what's happening then is, one, the distress is extremely high, and secondly, it prevents the person from living normally. So it can compromise their relationships, it can compromise their job, it can compromise normal living in their own home, independent living, because it's too scary, because they're too afraid of too many things going wrong. So that's the importance of, one, trying to get some intervention, whether it's your own work or with somebody, get some intervention sooner than later. And really focusing on how big is this? And if it's starting to kind of grow and take up more space, try and reduce it, because as I was speaking to Beverly about before this, ultimately the goal of any treatments with any disorders is for people to get back to what they're meant to be doing, right? You want to get back to being a mom, you want to get back to doing your job, you want to get back to being in your relationships and enjoying life. And so as this expands, other things are being reduced. And so when you start to see something taking up too much space, it's very important to do the work of putting that back into its smallest form so you can get back to what you're meant to be doing. I can see a lot of head nods. We're all on the same page about this, I think, yes. Okay, one of the questions was around whether or not you treat this and then you're done once and for all. Is this kind of a one-shot deal? I invest and then I'm finished. Well, finished in the good way. But it is important to recognize that generally the goal is symptom reduction and returning back to life without expecting that you'll never have symptoms again. Generally, the goal is not cure, and generally that's not the outcome that you can expect. But you can expect to have a significant symptom reduction and to really be back focused on regular living. And that's a worthy goal in and of itself. But the kind of useful thing to know is that it does have a curb, and you do cycle, and that's normal with any of the disorders, right? If you get depressed periodically. If you have generalized anxiety, you get anxious now and again. And, we talked a little bit about examples like around school. Oh my God, I can represent my clients right now. One little segment are the students. It's the end of the year and I got to find a job. And so you can understand how that stirs things up. or you're getting married, or your kids are moving away from school, or you're the parents of the kid who's getting married. Like, there's a lot that will stir things up. And at the root of this disorder is anxiety. So stuff that gets you really worked up is going to tend to stimulate a lot of symptoms. And so you don't want to be walking around worried, oh my gosh, what if it happens again? You want to mostly be anticipating that sometimes the symptoms are going to be a bit stronger and other times they're going to be less. And here's what I'm going to need to do when I sense that I'm having more symptoms or this is taking more space. I need to act on this. I need to not let this grow. So one of the things I find really helpful in working with people, it's not good news. They don't like it when I tell them it could come back. I'm not popular in those moments or on those days. But it's better because then when people get better, they get fearful. Oh my gosh, what if it comes back? Well, let's just take that right off the table. It may. And let's start preparing what are some of the conditions or what will be some of the things that you might notice that tells you it's kind of getting stirred up again and it's time to intervene. And let's prepare for it rather than being scared of it. So the treatments are quite effective, the tools are effective, and you just want to apply them and try and keep the curb as smooth as possible. And I think that in and of itself is a good goal to give oneself. And I left the last point, the best point for last. Treatment is very effective for most people. So the majority of people experience significant benefit from having it treated. And the cognitive behavioral therapy approach is a very effective means of intervening. So know that sometimes it's very difficult to get started, but once people are engaged with the treatment, it generally works. Still with me? Yes? Okay. All right. I sense maybe some questions around anxiety versus OCD. Is that just my own question? It's a good question. Okay. So one thing to know, and I won't get into professional details that are not interesting, but generally, and until recently, OCD was all part of the anxiety cluster. So a form of anxiety. So panic disorder is a form of anxiety, social anxiety is a form of anxiety, agoraphobia. So these are different manifestations or ways of experiencing anxiety. And the critical part to know is that at the root of it is anxiety. So sometimes one of the things that people find scary when they come in, it's like, oh no, I have anxiety and I have OCD and I have panic and and the good news is what you have is anxiety. It's not the best news, but it's better than thinking you have a whole bunch of things. Basically, at the root of all of this is anxiety, and it's a way that anxiety manifests. And for OCD in particular, it's a difficulty, a significant difficulty tolerating uncertainty, the unknown of what may happen. And you can see here the link right away with anxiety of what if, worrying about what if this happens and what if that happens. But in OCD in particular, these particular thoughts come back repeatedly, whereas in anxiety in general could be anxiety about anything. I was here an hour early because what if this and what if that, and seemed pretty critical that I be here for the presentation. So, that it could be applied to this, and tomorrow it's going to be something else. But it's sort of like anxiety, whereas in OCD it's like, what if I hit somebody with my car? What if I get a disease? But they tend to have the same one over and over and over again, and it stimulates them to engage in specific acts repeatedly to try and treat or respond to those. So it's just a really particular form of anxiety. I won't go into a lot of detail, but recently OCD was pulled out of the general cluster of anxiety and grouped with some other diagnoses. And there was some research reasons behind that around what are some of the neurochemical things going on. But for your purposes, I don't think that distinction is important. I think really mainly you want to recognize whether or not this is what you're experiencing and what kind of treatment you need. Did I already speak to these points? So the main components, repetitive thoughts, lots of distress and compulsions. Now, somebody had a question about the O in OCD. Did we address it? No? Has somebody withdrawn their question? So one of the things that sometimes comes up around obsessions and compulsions is, can you have obsessive thoughts without compulsions? And that does sometimes happen. Sometimes people just have an intrusive thought. Sometimes the intrusive thoughts just repeatedly come and they cause distress and they don't engage in a behavior. And sometimes an obsessive thought results in a mental habit. So if you have a distressing thought, it isn't necessarily an action that you can see, but they will engage in a mental game. They need to count certain things, or they need to imagine something else. And so they're trying to counter one mental thing with another mental thing. So you might not necessarily see what their compulsion is. It could be something mental and something mental. Some people have recurring obsessive thoughts alone. So that's also a possibility. But you want to look at the whole picture, and if you have doubts, you want to read the whole symptom picture to see if maybe what you're having is intrusive thoughts that's related to something else. Okay. In some cases, the thoughts are irrational, and sometimes they're distorted. That's a little bit about what we're, or maybe, I guess what I was talking about earlier, is that sometimes it's irrational that what the person is concerned about just couldn't happen or wouldn't happen. So it's an irrational thought. And sometimes it's a distortion or an exaggerated thought about the magnitude or the scale of what might happen. But the root of it, you can't argue with it couldn't happen, because it could. But the concern and everything that's built up around it is distorted or exaggerated and taking up a lot of space. Yes?
Yes, I'd just like to ask, is it working? What is the relation of insomnia to these disorders? Is it always is that part of the package deal, so to speak?
Well, in anxiety and conditions in general, difficulty sleeping is frequently part of the package. I would say this is not specific to OCD, but more anxiety and sleep is that, well, and I guess now I understand where your question's coming from, because, and even without OCD, when you get to thinking about something, everybody's going, yes, most of the time or often, it will disrupt your sleep. But it's not necessarily something that gets them at night. I would actually say that's more of an anxious person. They're worrying, and it will wake them up at night, and they'll get into their worry pattern. Whereas somebody who's having obsessions, it can hit them anytime. But in either case, the reverse is also true. So we were having a little conversation about cognitive behavioral therapy, and at the root of this approach is looking at the relationship between an event and how we think about it or how we interpret it, and then the emotions we have and the behaviors or the way that we react to it. But there is definitely a physical component that, so for example, being tired really doesn't help, as we know, right? So you can get into a loop. I know for my own sake, I feel like I have all the conditions when I haven't been sleeping. Like the resources for coping with things are limited. Your ability to see things in a grounded, sensible way is limited. You feel more reactive. The emotions feel bigger. So but I would say that the relationship is more between the anxiety generally and the sleeplessness, and you can kind of get into a loop. Okay. All right. So a few examples of obsessions and compulsions. One that is commonly known as the fear of contamination. So kind of one of the spokespeople for that is Howie Mandel, who went public about that to kind of raise awareness. And so, for example, he won't touch anybody or they'll wear gloves, or they will try and greet people because there's a very significant fear of being contaminated and becoming ill. So that's a really common one that people have heard of. The second one, I don't know if you're familiar with this one, but I bump into it a lot, is the fear of doing harm to others. So the fear that you could, and this is where you see the exaggerations and the distortions or the let me just come back to that. The distortions and the irrationality of it. That some people fear that they'll hit somebody with their car and they won't notice and they'll drive away and they'll hurt somebody gravely. So, and there is no particular reason for why this might crop up. And that's where a loop starts, because you start thinking, why on earth would I have a thought like that unless it was actually possible? So you can just see how a loop can get going. Or a fear that you'll get angry with somebody and not be able to rein it back in and do terrible damage when there's just no particular reason for thinking that this person would harm anybody. And so they get into a pattern of, then they have to figure out, how do I do? So for example, how do I treat this, or how do I handle this? So some people, well, you can imagine, won't drive. Or if they drive, they're driving extremely slowly to make sure that they don't hit somebody. Or they circle back and keep checking to make sure that they didn't actually hit somebody and not notice and forget. So it can be quite limiting. It can be quite intrusive. So it's things you might not think about, but it alerts you to, when you hear something that sounds a little odd, to try and ask more questions about how it works. So I'm jumping ahead to where we're going to talk at the end, but one of the things that can be helpful if you suspect somebody that you care about has this is to just try to be curious about it, okay? So what you don't want to do is react like, well, that's bizarre and that's ridiculous and that's not going to happen, right? Because then the person will just sort of go inside with it, or go undercover with it. I would tend to ask questions and try to understand how it works. And so you can get a better sense of, are we talking about OCD? And so that way it's not threatening for them. And somebody's interested and they're not judging them. They're just going to get closer to them and see what's happening and how can I help? How can I support? Let's understand what's going on here. Otherwise, they'll be inclined to hide it. Okay, so that's just a point on, because sometimes it sounds so ridiculous that our inclination is to say, well, that's ridiculous. Well, because on some level it is. But for that person, it's a very real fear that they're organizing a lot of their behavior and their time around, so it's very important to them. Excessive need for order. I mean, I think that's more my minor condition is around the excessive need for order. But when I find that really useful to look at, where do you put the line? And so often you think about how distressing is it that you absolutely have to do this, and how much time does it take? So people who like things orderly are often accused in layman's terms of being OCD, but it's kind of regular people, little form of OCD. But when it's really OCD, you'll see it's very, very exaggerated. It's very labor intensive. It's very emotional process. It's not like they like things a certain way. Things must be a particular way, or it's very, very distressing. So you can, one of the things that I found handy when I was looking for workbooks for my clients is sometimes you can, either in a workbook or you can tool around online, is that people lose a sense of what's regular, what's normal. So if we took the contamination as an example, when you go in and you wash your hands, like how much time do you spend rinsing under the water? Pardon me? 30 seconds. And that's probably long, right? If I did this, 30 seconds would be a lot of time. Most of us are probably not actually washing our hands in reality, in truth. So one of the things that's helpful is to really think about what would be regular. What are most people doing in this sphere, to get a sense of how far have we departed from regular stuff. So, and sometimes they'll have norm references for how long do most people start washing spend washing their hands. And then you have a sense that if you're spending 5 minutes, that's a long time. And so you have a sense that maybe I may have an excessive concern about this. And another way to tell is what would happen if I tried to reduce that? What if I tried to do it less? How would that be for me? So sometimes I learn, because we all have I grew up in the 80s. Well, I'm still growing up, but so a lot of the stuff that you learn gets dated around what you should do about your health or your hygiene or what you eat. And then you learn someday that, that doesn't work anymore. Stop doing that. You're wasting your time. drop, done. So you have a sense that you're not attached or you're not emotionally distressed about it. You can release it. So, for example, if somebody washed their hands a lot and you said, you don't need to rinse for 5 minutes, a minute, the experts would say a minute for sure has got cleaned off everything that you can, but a person can't stop. Then you have also a sense that there's a lot of emotions attached to that action. So just little kind of guidelines to have a sense of, how distorted and how distressing it is for the person. And I found that tremendously handy for myself, because I don't think much when I'm trying to work with somebody. Well, this one I've obviously looked into, but for others I think, okay, what would the regular range seem like on this, and then where are we at with this person, and then we can work, because part of what you want to do is see if you can pull that back into a regular health behavior, and you figure out what that is depending on what their obsessions are. So just a little handy tip for you there. Fear of contracting serious illness. So somebody had a question about hypochondriasis, I think. Yeah, so there is a variant which is fear of serious illness. And so what form can that take? Well, oftentimes people are, they have many, many doctors, and they're doing lots of investigation. So they're undergoing a lot of tests, and they're not letting the doctors know that there are multiple doctors. So they're hiding the fact, because they have a sense that this is an anxiety. Well, they can't tell you that, but there's a sense that this is not regular checking. And so they will sometimes protect that information so that the different professionals aren't aware of all that they're doing. So another form is how much time they spend Googling. I mean, so you can imagine. And there's an example. Anybody who worries that they have a symptom, like how many people in this room have Googled when they had a weird symptom? And I don't believe the rest of you. Well, I mean, it's just you look it up somehow, right? It's a natural curiosity, but you have to see how much looking are you doing and how far are you going with that, and what impact is it having? And most of us stop Googling, right? Because it gets more scary rather than less scary. So we stop, we turn it off, we X out of there, because we think, you know what? I've learned just enough to say, I'm going to go get this checked out for reals. And that's probably what's going to help me. So you're looking for what are the behaviors around this worry? How extreme are the worries? Is there any grounds for it? What are the facts around this, and how are they going about trying to address that? And so an example is sometimes we see people who have been to every specialist, and they're being followed, and the doctors have set like a follow-up period, and everything's being done that can be done to make sure this person's okay, and that their symptom checks out and there isn't anything undetected. But you can imagine that with medical illness, I don't know if you guys have any guesses about this, what might fuel this in medical illness? Obsession. Pardon me? Obsession. Well, yes, obsession can definitely fuel it. The unknown. A doctor can never tell you for certain that you definitively don't have something, right? So that doubt is what keeps them in the loop, because as much as they can test, and all they can tell you is, for what we can see right now, there is no evidence that you have this condition. But that doubt keeps people wondering and searching, and you can't. And that's the difficulty that we work with people with anxiety in general, but OCD in particular, is trying to accept a certain amount of doubt that nobody can close for you. We all have to live with a certain amount of doubt that there's nothing we can do about. And that's exceptionally hard for people who have OCD to accept. And so they engage in different ways to try. And the idea of the rituals is to reduce that anxiety associated with uncertainty, but it doesn't work. And oftentimes it fuels. And they have to do more and longer to try and quell the feelings of anxiety. Preoccupation with blasphemy or sacrilege, so depending on what the person's belief system is, believing that they're engaging in sacrilegious behavior. That can be obsession, or fear of sexual perversion is what it's called. But whatever the person finds scary or unacceptable around sexuality. So, for example, there's HOCD, so fear, obsessed with a fear that they might be homosexual. So this was a specialty that was developed because for some people that would be a fearsome, unacceptable outcome. And so there's a lot of fears, and you can imagine what can happen sexually then when you're carrying all this fear around in terms of how you perform and how you react to people of the same sex and the opposite sex. So it's their constant filter, is what they're fearing. Is this a confirmation that I am or I'm not? This kind of thing, or who I'm attracted to and what does that mean about me? So that's another form of OCD. Okay to keep going? Any questions so far? Did I really just think of everything and put it in here? That almost never happens. Okay, treatment approaches. And you can tell me if you want me to go into a little bit more detail about CBT. I'm not sure what your familiarity is with it generally, but it remains the most effective treatment for obsessive compulsive disorder. It's I think Beverly was discussing it earlier. It's one that's been researched as early as the 60s and continues to be demonstrated a highly effective treatment. So if you're out looking for a treatment, whether it's in books or whether or not it's therapist, I would include that in my search terms. There are also some interesting books that combine CBT and mindfulness. I've mentioned that. Mindfulness-based therapies are also useful because mindfulness-based approaches also incorporate thoughts, how you react to your own thoughts. And both of these treatment approaches, addressing thoughts or how you respond to thoughts, is a fundamental part of the approach. And as we were talking, or as I was presenting to you about OCD, the thoughts, the intrusive thoughts and the impact that they have on the person are fundamental to the disorder. So you want a treatment approach that is going to intervene on the thoughts because they are fundamental to what the person experiences. And the rituals are to respond to the thoughts, right? So you need to go after the thoughts. Now, the cognitive behavioral approach is really goes into the thoughts and understands the thoughts, but there's what we call, well, I guess it's on my next slide, but we goes into exposing the person to these thoughts, the things that they fear, to actually be able to face the thoughts that they find intrusive and distressing, and to prevent them. It's called response prevention, prevent them from engaging in the ritual, or curb the ritual, or reduce the ritual as a way to address both thoughts and the behaviors that go with them. So you do whatever approach you take. And so this is a question that often comes up is, what about more dynamic or psychodynamic approaches? The insight-based therapies can be useful, but particularly if they build insight that we're dealing with obsessive compulsive disorder. It remains true after that. You still need to deal with the obsessions and the compulsions. So the insight is extremely helpful, but doesn't in and of itself treat the O and the C. So that's what you want to be looking for in your treatment approach, is how are we going to actually tackle that. And insight, as I was having a little side conversation with Beverly, the trickiest part, okay, there are a number of tricky parts, but a very tricky part of this is the insight piece, because some things are very difficult for people to let go of, that it's OCD and not truth. So some people feel really quite tightly convinced that what is going through their mind is truth. So, for example, some people have quite developed germ theories, and they've really gotten into it and are really believing their own thoughts. And if so, they're not likely to let go of the ritual because they believe it's a real danger. So one of the things that helps people is to fully acknowledge that the thing that's going on is OCD and not a reality. And so there's often work to try and diffuse or detach those two things. These are intrusive, irrational, or exaggerated thoughts, and that's different from facts. And so that front end piece of really understanding what's going on is critical to then being able to respond differently to the thoughts and respond less through behaviors to address that perceived danger, if that makes sense. Yeah? I'm not usually this clear. Everybody seems to just get everything. Fabulous. I like the way 2017 is trending. This is going well. Okay. Let me just see how I can go into this. What does CBT for OCD consist of? It does sound like alphabet soup to me. Okay. Exposure to thoughts. So one of the things that is common in any form of anxiety, but also including OCD, is avoidance. And so anything that causes intense anxiety creates a natural inclination in humans, in all of us, to back away from the thing that's scary. But as you know, if something scares you, what's the thing you need to do? You need to face it. You need to move toward it. So any of the treatments that address anxiety ask us or invite us or help us to do the thing that we don't want to do, which is to move toward the thing that's scary for us. For people with OCD, that's the very thought of whatever it is that scares them. So imagine if you feel you're going to harm somebody, it's such a scary thought that you're trying to avoid your own thought. And so they'll either engage in a ritual or they'll try and hook their mind on something else as a way to not have to connect with that thought that's very, very scary. So part of what's difficult, effective but difficult in the treatment, is having people face head on the thoughts that they've developed all these techniques around not having. And that's the only way through. So one of the things that naturally families will do, individuals will do, and all of us as therapists have to avoid doing is just trying to reassure the person. Don't worry, it won't happen. And why don't we want to do that? Pardon me? Because it could possibly happen with the answer. And it goes counter the belief. Because the reality is a lot of the stuff that people get obsessed about could happen. And we have to build up a tolerance to the more grounded reality or possibility that it could happen. Because it could happen, but it's just not as likely or as big as the things that we tend to worry are going to happen, right? So scaled back to regular, we need to be able to tolerate that amount of uncertainty or unknown about something scary that could happen. And so do they. Sorry, we had a question.
I was just thinking, I think you also don't want your client necessarily to come to you for reassurance. I feel like that's not your role at the same time, whereas that should sort of be developed in them intrinsically.
Right, so the person said, we also don't want, as a therapist, for the person to feel like the only way that they can feel better is to get the reassurance of a therapist. Because in any kind of therapy, you're trying to cultivate, ultimately, their independence, but it's like another ritual. I'll go to my therapist, and then they will say reassuring things to me, and I'll feel better, but it doesn't stick. It's not lasting, it doesn't build independence, and it doesn't expose them to the stir that's created around that uncertainty. So we're trying to bring it back and put it in front of them. And one of the things that we obviously need to help them do is to be able to manage their anxiety as we do it. So part of any anxiety treatment, if it's panic or generalized anxiety or social anxiety, is we're trying to bring the overall level of anxiety down. Because if somebody's always firing on this level and then you expose them to something scary, it gets into the intolerable level pretty fast. So one of the things we want to do is overall help them to engage in techniques, relaxation-based, breathing-based, meditation-based, to try and get the anxiety level down so that they can be in front of something anxiety-provoking. So we don't want their anxiety way up here. So that's part of the approach that we would incorporate. And response prevention is modifying or refraining from the compulsive behavior that normally goes with. So if they're being exposed to the thought, and generally people do this progressively. So as you can imagine, when you're scared of something, I don't like when somebody tries to push me to do the thing I find scariest right out of the gate. Like, I think about a deep pool of water, like I put my toe in, then I might kind of work my way in. So, for most people, and it's even if it's not OCD, just for people who don't have any kind of particular anxiety condition, you progress gradually. And so and with accompaniment often, right? To bring somebody along who's going to help you through the process. They're neither going to force you in quickly or leave you alone. So you think about all the normal conditions that help people do things that are scary. So it is a progressive. So for some people, just changing the ritual, because they tend to be quite rigid about them, is an improvement in and of itself. Because it creates a little wiggle room that if it can be different, then it can maybe be removed, but different is already a good start. So if they tend to do it for 20 minutes or 3 repetitions, could it be 2, or could it be 1, or could it be something else? And this is just to try and shake loose this relationship between I have this thought and I absolutely have to do this thing this many times. So that's kind of a paraphrasing or a description of how it goes. I think I described the other pieces. Pace and intensity can be modified. So for some people, there's a bit of a warm-up period, or a lot of one. So some people are recognizing, they're pretty sure this is OCD, almost 100% sure, but they're trying to get ready for, are they prepared to do the therapy work and start tinkering with things? And that their anxiety can be quite high. So sometimes it takes a bit of time just building a relationship with the therapist and trusting them and going very, very gradually. Any movement forward is movement. And at some point we have to decide, okay, we need to start pushing into the thoughts and the rituals. Beverly, you had a question?
In many mental illnesses, you have the patient that is in denial. They just believe they're fine and they don't understand what's wrong with everybody else. Do you have that type of situation? It's called anosognosia. And does that happen with OCD, or do they fully realize and accept the fact that that is what they have?
Well, that's certainly what differentiates people who can engage with the treatment and those who can't. So, and to your point, some people fully believe it, and if they do, you can't do the treatment. So if that's true, then you have to be first working on helping them to understand that that's what this is. So there are people out there who are walking around and who engage in all of this, who deny that that's what it is, and they would not be candidates for treatment, because even those who acknowledge it, it's hard work. Like it's difficult to do, to face these scary thoughts and refrain or reduce or change the rituals. So sometimes it will happen that parents are convinced and they recognize it and they want desperately for their kids, and they'll bring them along. But if that person really doesn't believe, or is, it's a little difficult at times, because it's very slippery, because it is something that's sort of true at a different scale, but at the scale in which they're living it, it's definitely OCD, so it will slide. It's very challenging if the person doesn't believe, because even when they do, it's tough, to be fair. Okay, so the pace and the intensity can be modified, and I find that people who are pushed, they're there often because they know that left to themselves, it's too much. It's not something they can do on their own, and so they appreciate that a certain amount of of tension is placed there to move forward. But the pace can be very gradual. So we don't want it to be we don't want to create a jarring experience, but we do want to put some tension that we get into the exposure and the response prevention. Otherwise, we're not helping. But like I say, sometimes there's just a warm up to get used to the idea and how it's all going to play out, and to trust the therapist that they're working with. And the treatment length depends on severity, readiness, and capacity to actively engage in therapy, and also how developed it is. So for some people, I mean, and it really varies. I know I'm giving you the standard psychologist response. It depends and it varies, which everybody doesn't appreciate, but it's true. That's why we say it all the time. But so for example, some people have quite an elaborated life around the OCD, where there's lots of rituals and so on. And I've seen it work both ways. I've seen for some it took longer because they had more to dismantle. And I've seen others for whom, once they understood how it works and how it's playing out and what they need to do after they've undone a couple, then it goes much faster for the others, because they understand the principles, because how it works doesn't vary depending on what the fear is. It works the same, it just is manifested differently. So I've definitely seen people who had a bunch of variants of different rituals, and once they got a couple figured out, they moved to the others and was quite successful. For others, they move very gradually. They'll tackle one and it takes quite a while, and then they move on to the other. That's all fine, you know? Mm-hmm. I was having the conversation about acceptance. What the gentleman said was, what is key to moving forward is acceptance. And, you know, we were having this sidebar conversation just before you all arrived, which is, that's a really hard part of it with any of the emotional difficulties, is accepting that it is, that you have anxiety, or that you have OCD, or that you have depression. And then once the good part is, once you've accepted that it is, then that energy that you're spent, that is tied up in fighting its very existence, is available to do some good work, right? So, and it already does exist. You're acknowledging it doesn't make it more true. It's already present. It's already affecting you. But so it's good to just call it and say, you know, I'm having a hard time accepting. It's unfair that I have this. How come I have this and I have to deal with this and other people don't have to deal with this? They're just busy studying and I'm trying to study and I have this. It's not fair. And you know, it's not. Like, that person didn't bring this on, but it's theirs to deal with nonetheless. Now the person sitting next to them has something else to deal with, and the next person, so we try and work with them on, yeah, no, it's not fair and nobody wants to have to deal with this. But it's taking up more space in their lives than when it's not being dealt with, and the battle's all about having it or not having it. Because once you get to that point of accepting, I don't like it, but this is what is, then we can get to work on trying to make things, improve things. So I totally concur, yes. Yeah. Well, and you think about the severe stress, so just to summarize, because you might not have all heard that, is that for you, the magic combination was managing stress and having the right medication. And when you think about the stresses we were talking about, that generates a lot of anxiety. So when people are under intense pressure, they break in different ways. So some people will come burnt out, and other people will become more obsessive or more anxious or more angry. Like, it comes out in various forms. And so part of the recipe, I mean, the one thing about what you said that I was surprised about was that you managed to avoid stress, because I'd love to, maybe we'll talk after, you can tell me what your secrets are. I've never been able to avoid stress, because often, like, life just comes with stress. You know, it's an interesting point that you share, because I've noticed that, you know, when people come to us, and I promise I'm going to come back to the topic in a moment. I haven't forgotten what the talk is about. But people come with depression, or they come with anxiety or OCD in particular, or other things. And that absolutely needs to be addressed head on. They need to manage the symptoms and come back to being able to be functional, even happy, where ultimately, but frequently there's something quite wrong going on. You know, often with time, as we unpack things, we find out that something in some domain is really not working for this person. And the ultimate, I don't want to say fix, because we don't expect to fix things. That's a word we avoid using. But the ultimate solution for things getting much, much better is to also be able to address that big thing that's not working for that person. It could be a job. So you mentioned, you know, you started to teach art, and you couldn't be happier than to be giving back through art. So sometimes people are in a job that's a really, really bad job for them or a really terrible boss, or in a relationship that's a terrible relationship for them. And we will work on managing their anger or their sadness or their anxiety, and we'll have some effectiveness. But ultimately what makes a big difference is we start to move into how do we make some changes in their life that's also going to make that person well globally, then they're going to have less symptoms. So thanks for pointing that out. The medication also is a good reminder, is often a part of the solution for many, many people that helps a great deal. So I mean, if in order, I would do two things in parallel. I would consult my physician and get a referral to psychiatrist for the medication piece, if that's something that you're open to. Not everybody is, but it's definitely a consideration. And I would get signed up to go and consult a psychologist, a psychotherapist who's qualified to do that. Oftentimes people are not ready to move into all these big parts of their life. It's gotten focused in this one particular area, and that's what they're prepared to talk about. But as the relationship builds and as the symptoms start to become more manageable, then you get to more access to other stuff that's going on that would be really helpful to address. Yeah. Thank you very much. All right. Oh, we have yes.
Like, what are some tools?
Okay, you're next.
I'm sorry.
Okay, no worries.
What's the recipe, if there's any such thing, to assisting somebody in recognizing that they have this issue, if you like? Mm-hmm. How do you help guide somebody towards that recognition in order for them to be able to start treatment?
Mm-hmm. Well, so there's no recipe, but there's some ideas. I'll go with that. And it really depends on the person, and that's where I think you are better placed. A family member or a friend or somebody close is the best positioned to know what is likely to reach that person. So, for example, I was talking to Beverly earlier around this was with a client, but I do this in my own social circle. Neighbors bring me things, family brings me stuff. And I like to see, like, when stuff's going on with this person, not this in particular, but other stuff, how do they tend to approach it? Like, do they read stuff? Like, I know for me, like, I need to grab books and take it all in and then decide where it all lands. Others are videos. Others are Googlers. Others, they need to talk to somebody who has it, or somebody who did have it, or somebody who's a specialist. So I get sent people's kids all the time. Go talk to Francine. Say stuff to her. And you don't have to involve me, but I know you'll feel comfortable. So I would pay attention to the person that you know and you love. What stuff tends to reach them best? So if they're readers, some parents or some will go and get themselves a book and take it in so that they are informing themselves. And it also means that there's a book around on the topic that the person could leaf through if they were interested. And you're not saying accusingly this, you're just like educating yourself. And you know that books are likely to work, kind of thing. My approach, I have a 13-year-old son, and if I come after him with questions, no deal, not going to happen. But if he's in distress and he's at loose ends, like you got to be really at loose ends if you come and ask your mom, the psychologist, about it, because she's like, you know what I mean? He could tell you about it sometime. He says, I'll tell you, but don't ask me follow-up questions. But I know that when he's distressed, actively in that moment is my best teachable moment with him. And so I try to get real close to it and just let him say a lot about it so I can get a sense of what it is that is going on. And then I'm looking for other moments that same thing is happening, to go, is it just like then? Is it just like then? To sort of start to build up a picture that this is not an isolated incident. This is a thing. Is it like this? And they don't have to be scared of me. They don't have to hide from me. I'm their confidant, for lack of a better word, in this, and they can come to me when it's going on. I could also be then the person who could go talk to somebody with them, who could read with them, so you become the buddy in the discovery process. So, and those are often, information sessions like this are a good example. If they won't come or you don't think they'll come, you come. Because the more you have information, the more you're pretty sure that you're dealing with what you're dealing with. And some people are good with a frank conversation. That depends on the person. And you know, like, and if they get upset with you, they might get upset with you. But when it comes to a family member that you're concerned about, you know, you just gauge your words and your approach, but sometimes you just need to put it on the table, and that works well too. Yeah, so I find the best clue for me is like, what do you know about this person, and how do they like you to come at them, and how comfortable are you to what's your comfort level too with how you come at things. You had a question also.
I had the exact same question actually.
Oh, there you go. 2 for 1. You guys are organized tonight. Yes.
It's the same related to my daughter, so it's a very complex case, which is, I will go later on.
Okay, you're going to come, we'll circle back to your question.
Yeah.
Okay.
It's the same topic.
Type.
Yeah. So person doesn't want to accept some criteria which she's going through, so I will later on.
Okay, we'll come back. We won't forget you. Okay.
That's the reason I am here.
Yes, yes. Well, and, you know, I was careful to say we discuss ideas because there's no one solution, and, you know, people are coming at it, and it's tricky if the person won't acknowledge or actively denies. It's a very difficult thing, and we are aware of how distressing and how disruptive it is, so we're very keen, very motivated to try and get them to that point without forcing it too much, so we don't force them into hiding or resistance to us, because we're meant to be one of the allies. All right. May I ask a question? Did you figure this out yourself, or did a family member help?
That I had.
Mm-hmm.
I think I probably figured it out myself.
Okay. No, I'm just anticipating.
It was so long ago. It really was. You know.
Okay. Well, things pop up that you'd like to add in. You feel free.
Okay.
Okay. So how do I find treatment? So this is where Googling's helpful. And I did it before I came here just to see how much stuff would come up. And there are a good number of clinics. I mean, there are only a few that are CBT clinics, and there's a few. But you really want to get into the specifics of, is this person naming that they work with OCD, and is this person naming that they work in CBT? So I would look for that combination. And sometimes you get general profiles, but go into the profiles of the practitioners and look for the specifics, yeah.
About the CBT program, it's going to be
The Queen Elizabeth?
Queen Elizabeth, yeah, hospital. But I've tried to call there, and I end up with some building where Air Canada is, and so. Like, I haven't been able to reach.
We have a
hospital.
pamphlet here with an address and a phone number.
The right phone number.
Yes.
Okay. Thank you. Thank you.
And if ever you end up with Air Canada, reach me or Beverly. We'll get you through.
Yeah, well, I left messages, and someone from Air Canada called me, and they said, "Well, we're in the same building, but it's like a random building.
Oh.
Yeah, so
wow.
I don't know. Anyways, thank you.
Well, I'm glad you're persisting. That's a new one. That's the first time I've heard that one, yes. I've heard a lot of things, but not that Air Canada is referring people back to us. Well, I'm glad that they are, if that's true. Yeah, we can handle the people who are afraid of flying for them, maybe. Okay, so the 2 key words, OCD and CBT. Oh, sorry, did you have a question?
I was just wondering, most of the people I work with have much lower incomes. Most of them are on welfare.
Mm-hmm.
And the problem with these services is that the wait lists are extremely long unless you have the ability to pay for it. Thank you.
So I was wondering if there are services that are available, maybe on a sliding scale, for people who have lower income, because for the most part, not treating them, but at least supporting them has fallen onto, me as an intervention worker, a social worker.
Well, so yes, this is true about OCD as about all the emotional difficulties, unfortunately. So sliding scale is one of the things you